and to live here, and I appreciate and respect those who have honored and tended to this land. Today, I will propose a thesis to you. I hope that you will question and criticize it so I can strengthen it. We have 30 minutes for this, so I've set up a Padlet to capture your input. You can access the Padlet at the link on the lower left there, or by typing in to the link that's there. There are questions on the Padlet for you, and there is a free column for suggestions, critiques, and questions. I will stop periodically to address some of your remarks. And those that I cannot address today will be captured on the Padlet so that I can consider them later. So please do put thoughts in there as we go through this. In this proposal, I will describe to you how the training of applied epidemiologists may not be suitable. Then I will propose what I intend to do about the situation through 4 research projects. Finally, I will highlight how this thesis could contribute to the field of field epidemiology. Let me clarify what I mean by applied epidemiology. The standard explanation comes from a paper by Koo and Thacker, who graduated from the first applied epidemiology training program, the US CDC's Epidemic Intelligence Service. Field epidemiology is the common term, and Koo and Thacker reserve that for the most urgent health problems. They use applied epidemiology as an umbrella term for field intervention and shoe leather epidemiology, which are essentially synonymous, and all having the characteristic of epidemiology for action. They contrast applied epidemiology with academic epidemiology, and the key distinctions are that applied epidemiology tends to be more urgent, have more variable data quality, favor practicality and impact over rigor, and be learned in the field more than in the classroom. Most applied epidemiologists learn through applied or field epidemiology training programs, or FETP. These programs typically sit in ministries of health, though some, like Australia's, the Master of Applied Epidemiology here at ANU, are in universities. FETP traditionally lasts 2 years and include about 25% didactic instruction and 75% field-based learning in a national or local health department or institute. In many countries, FETP is one of the most valued resources for public health workforce development. I studied epidemiology in an academic program and learned field epidemiology when I was thrown into outbreak investigations while working at US CDC. My relationship with FETPs over the last 15 years has brought me to ask questions about the training approaches and to propose this thesis. While at CDC, I deployed to outbreaks and guided trainees or EIS officers in the field. I trained government epidemiologists in Central and South America. Later at Japan's National Institute for Infectious Diseases, I was an FETP Japan staff member. Then at the World Health Organization, I mentored, trained, and supervised FETP trainees and graduates in Asia and the Pacific. I was surprised to find that across these cultures and contexts, most trainees prefer to learn through small group discussions, hands-on projects, role plays, what we might call active, experiential, or empowerment education. Yet most courses relied on a cognitivist, one-way knowledge transfer, typically through PowerPoint presentations. FETP find their origins in the US CDC's Epidemic Intelligence Service, or EIS, which started in 1951. Alexander Langmuir, who's pictured here on the ball game, was the first chief epidemiologist at CDC, and he designed EIS. Its first cohort had 22 white male physicians and 1 statistician. Since then, EIS has graduated 4,000 people, some of whom became CDC directors, assistant directors general at WHO, and public health school deans. Many credit EIS with strengthening or building the US public health infrastructure. In 1975, programs began to appear in other countries. First was Canada, then Thailand, Indonesia, the Philippines, Mexico, Peru, etc. Today, more than 2/3 of the world's countries and territories have programs, which now include an intermediate level of 9 months and a basic or frontline level of 3 months targeted to local health district surveillance officers. Almost all FETP came from the EIS model. So one model, delivered to white male physicians in the 1950s USA, spread across the world to programs with multiple genders, dozens of cultures, languages, educational backgrounds, and various government, political, and economic contexts. That spread alone brings questions, like how do we know if the training model is right in these contexts? How do we know if fidelity was maintained over this time, or if it should have been? How do we know what parts to adapt and what parts to keep? And what if adaptation meant the loss of something essential? These questions are not intellectual exercises. Field epidemiologists are the reconnaissance arm of health emergencies. They get information, they understand its quality, then analyze it to inform decisions to prevent and control the spread of disease. This paper in the lower left talks about their massive contribution to COVID response. The WHO evaluation tool for the international health regulations, here on the right, the Joint External Evaluation Tool, sets a target for every country to have at least one field epidemiologist per 200,000 population. And a graduate of an advanced or intermediate FETP has come to be the proxy definition for that. If graduates and trainees are improperly trained, we have a problem with IHR and our ability to respond to emergencies. Amy Perry, who recently submitted her thesis in this school, found many people graduating from these programs had not been prepared for skills such as risk assessment, needs assessment, and estimation of population sizes, as well as social and communication skills, leadership, and management. The respondents and the authors suggested the approach to training needed to evolve. In order to evolve, we need to know more about the current training approaches. Unfortunately, the literature does not answer our questions. FETP tend to describe their training programs in general terms, saying it is based on EIS or it's learning by doing. James Flint, a PhD student at the University of Newcastle, has written a review of FETP evaluations. The review has not been peer-reviewed, but it has noted that while programs have published lists of outputs, like the number of outbreaks investigated, few present outcomes or impacts. Those that do share only success stories, not systematic evaluations. My literature search has found few papers written on training in this field, and those few papers report trainers' anecdotal experiences, including my own. So this thesis proposes to explore learning in applied epidemiology training programs to inform principles and processes for designing and implementing better training approaches. I want to just stop and take a look at the Padlet and see if there are any, looks like nothing yet. So please do, are people able to access it? Yeah. Has anybody posted and I'm missing it? No, okay. Good, you're attentively listening. Okay, so yeah, so please do, I'll stop again in a few more minutes, but since there's nothing there right now, we'll just continue. Okay, so to ensure that the questions I'm asking are relevant and useful, I have been meeting with a group of applied epidemiology trainers from Australia, Fiji, Japan, Mongolia, Papua New Guinea, and Taiwan. We meet monthly to discuss training and learning and to figure out how we can research it. I'd like to acknowledge and thank Emma Field, Scott Anesi, Tomoe Shimada, Mungsul Batsen, Bernadine Smagi, and Angela Song En Huang. I also want to acknowledge and thank my supervisory panel, Martin Kirk, Tambri Hausen, and Barbara Pamphilo. So, in the first project, we looked at the original EIS through the lens of adult learning. The goal was to find a theory of learning or a theory of training underpinning the model. Unfortunately, they didn't describe one and publish it. So we selected 4 established adult learning theories with different perspectives. Malcolm Knowles' Andragogy, David Kolb's experiential learning theory, Jack Mesereau's transformative learning, and Levenwinger's legitimate peripheral participation in communities of practice. I reviewed the published literature describing the original program, so 1951 to 1970, which was the time that Langmuir was the director. And I compared those descriptions with the core elements of these theories and discussed what I found, the preliminary findings, with the training group as well as with my supervisors. I was surprised to find that EIS aligned with andragogical principles, the experiential learning cycle, and promotion of legitimate peripheral participation in communities of practice. This preliminary finding suggests a complex training system based in the humanist tradition, which may explain why it was so good at developing not only applied epidemiologists, but also public health leaders. Transformative learning, specifically the promotion of critical reflection on the assumptions underlying learners' frames of reference, did not appear in the descriptions that we reviewed. This preliminary finding implies there was no intention to foster awareness of why trainees know what they know and believe what they believe. I feel this finding will have important implications for the dissemination of the model into so many contexts, as well as our understanding of public health leadership. The paper for that project has been drafted. For the second project, I aim to describe the historical evolution of the training model from that early EIS to the FETPs of today. Amish Talwar, who's a PhD candidate in this school, is helping me on this project. Thank you. We are reviewing the literature and will interview key informants who were involved in setting up, especially the early programs. And we hope to identify eras or major changes, any reasons for those changes, and any global macro trends that might parallel those eras or those changes, as well as any other patterns in training during the dissemination of the model. We expect to complete the project by June, right? Okay, this one gets a bit complicated. The third project explores training and learning in today's applied epidemiology training programs. The trainers that I named earlier are co-investigating this. We're approaching the project from a critical action research framework. That is one that aims for change. So explanations and understandings are not the goal. They're just steps towards change. In our context, that would be to transform training by revealing alignments or misalignments between practices, understandings of practice, and situations. Our method will draw from grounded theory, which is a sociological approach to qualitative research. It's similar to hypothesis generation in an outbreak investigation, the early parts of an outbreak investigation. You start by gathering data from an initial sample and comparing incidents in those data to generate theoretical explanations. The comparison of incidents also will suggest additional data to collect, which is a method known as theoretical sampling. And we continue in that way until saturation. So we'll use grounded theory to explore how trainers and trainees perceive learning and training. and then look for the alignments and misalignments between practice, understanding, and situations. The data will include participant observations and in-depth interviews with trainees and trainers from the 6 programs that I named earlier. We've received provisional approval from the ethics committee and expect collection to start in December, probably until next November. The 4th project will be based on the findings of the first 3. It may involve a quantitative survey into the representativeness of the findings or into barriers and enablers for changing training design or practices, or some other question. We expect to begin this project in September. Okay, so one more time, I'm going to stop just very quickly and see if there are any, okay. Thanks for putting your questions up here. Okay, so one question is, are there adult learning models and theories that could be drawn from the Global South to evaluate FETPs? Yes, theories is a bit challenging to say, but there is literature about it. And most of that literature is challenging the adult education theories that mostly come from white men, the US and the UK. So there is entire literature on decolonizing education that I think will be incredibly important for informing this dissemination, but also interpreting the qualitative study that we're doing, the findings that we're getting from different contexts. In addition, there are some recent papers, not recent, there's some recent to me, new to me, papers from Africa also challenging the same sort of hegemonic approach to implanting Western-based or Western-based adult education theories on populations of different contexts. So yes, there is, and I will definitely bring that in. It's not lost on me that the looking at the original EAS model, we're basically using, well, 3 white men and then another couple that's a man and a woman, European and American, but that's not lost on me. But I do think that, you know, that program came from 1950s US white physicians. So I think it's appropriate to at least look at that one with those theories. But then when we talk about what does that mean for disseminating around the world, then I think it's really important to bring in the non-Western theories, or from the Global South, as you say. Okay. Could you interview and analyze? I think that's a consideration, so I'll take that one into account. Okay, so a question is, are you looking at the overall changes in FETP trends or country-specific adaptations? That's a good question. We're really looking for trends, overall trends, but those are going to be informed by country-specific adaptations. So if we start to see, for example, that countries are adapting, then that's a trend. But on the other hand, if we start to see that countries are not adapting and they're just sort of receiving the curriculum from abroad or from CDC, that's also a trend. So it's almost looking at specific examples of countries and then trying to generalize to make trends in that way. And how would you gather this country-specific information, right? We're starting with what's available in the published literature. There's actually quite a lot. Unfortunately, it's not very deep. They don't go into the training and the reasons for training. It's just very, look how many outbreaks we've investigated and look how many people we've graduated and we need more money, this kind of thing. So we're going to interview some people who were involved in the beginning of programs, especially the earlier ones like Thailand and the Philippines, here as well. Okay, so I'm not going to get to all of them, but thank you for those. I do want to make sure we get done on time. And please continue to put suggestions or questions in there. As I said, I can use those to proceed. Okay, so COVID-19 has piqued interest in, well, epidemiology in general. Finally, people know what we do. But COVID-19 has piqued interest in applied epidemiology training programs. As an example, the WHO Assistant Director General, who you see here, has written that the COVID-19 pandemic and the ongoing multi-country monkeypox outbreak have shown that competent field epidemiologists are needed worldwide now more than ever. He added, our source of pride, and what he means by our is field epidemiologists. This was given at World Field Epidemiology Day. Our source of pride should not come from deploying international staff for every outbreak, but from having sufficient national trained staff to drive the local and national response. For many countries, FETP is the training ground for the public health workforce. So training itself has the potential to transform the public health system. We need approaches that prepare trainees for the uncertainty and the ill-defined situations of an epidemic. But we also need approaches that empower staff to alter the curricula and the program design for their trainees' needs and the country contexts. Those approaches will foster ownership and sustainability. To do this, we do not need more competencies and curricula so much as we do theoretically driven, contextualizable principles that inform program design and trainer practice. By exploring the theoretical base of the training model, describing historical forces that influenced its dissemination and impacts, and pointing out alignments and misalignments in current training practices, understandings, and situations, this thesis could generate those principles. So I'd like to stop there and check if there are any questions online or additional questions in the room. Or if there's I can see Tambri is there with the Papua New Guinea crew. Thank you for joining. Good to see you all. Any comments from your location, Tambri?
Just that they're all here in solidarity with you, Matt. Very happy the connection's lasting for us.
Great, thank you. Looking forward to seeing you all. Any other comments or questions in the room? If not, there's a question here. While you're investigating the learning model for FETP, do you know how traditional epidemiology training work in terms of learning theory? No. There is literature there, much more than there is in our space. It's a bit surprising that, we in the field epidemiology training program, the whole FETP enterprise that's been going on for 50 years or longer, 70 years, there really isn't a lot of literature dedicated to this. And if you look at nursing or you look at medical education, there's huge fields. They have entire conference sections dedicated to people who just study how to train doctors and nurses and this kind of thing, veterinarians, et cetera. But it's really lacking in this space, or it's just starting maybe. Yes, I started to get into that literature, but I quickly cut it off. Anybody who's doing PhD knows you have to sort of pick your battles and avoid the rabbit holes. So that was, I know it's out there, but I can't really speak to it because I haven't gone deep into it. Another question, how will you ensure that your background experience knowledge will not direct the grounded theory in a particular way? I cannot. I think one of the biggest problems with reflexivity and biases are that we should be more concerned about the biases we're not aware of. And so when we write a reflexivity statement, we're also choosing what we want to say. I mean, it's really impossible to write your entire universe in a reflexivity statement. And so the more concerning things are the ones that are the biases that we're not aware So I do think it will influence my interpretation. But this is one of the reasons I brought in, I've requested trainers from different groups to join this. So in interpreting findings, I'll bring those findings de-identified to them and try to interpret it as a group so that it's not only my interpretation, it's trainers from different programs, different cultures, different languages, different genders, different ages, different experiences, et cetera, who are also interpreting those findings. I should start, great quote from WHO Chikwe, right? Okay, so I should stop here. We're at 58. I really want to thank everyone for joining, for those of you who came in the room and for those of you who dialed in. And I will, there's also expected, oh, that's a different one. Okay, I will keep these, the Padlet open, so please add suggestions as they come to you. If you are reflecting after this experience and you want to add questions, comments, or suggestions, that's open, and I will consider those and incorporate those as I can. So thank you again, and especially thank you to our friends in PNG who have joined, and everyone else who's joined online from across the world.
Good job, Matt.
Yeah. Oh, no, it's not. Did you put the code up? Yeah. Yeah.
Great presentation, Matt. Thanks.
Oh, thanks.
See you, PNG.
Ciao, ciao.
Ciao, ciao.
Thanks for joining us, everyone. We'll see you again next week. Thank you.
Thanks.